Today, the first talk in our family education series will be entitled Understanding and Breaking the Stigma Surrounding Early Psychosis. And so this is really a foundational talk about the basics of first episode psychosis. And subsequent talks will get into communication strategies and coping strategies. So what we'll cover today. Really tried to make this kind of family friendly. If you're looking for more information, you can always ask. I can give you more resources or more in-depth research studies, but we'll focus on what psychosis is, as well as some of the things it isn't, what symptoms look like, a bit on why early treatment matters, some foundation about basic risk and vulnerability to developing psychosis, and then we will talk with you a bit about how our statewide learning healthcare system, the STEP Learning Collaborative, can help both families, providers, and young people impacted by psychosis. And then Aisha will show us some common myths and correct those with appropriate facts. All right, so to start off by understanding psychosis. So what is psychosis? What does it mean when I'm talking about psychosis? I think of it as an umbrella term, a medical condition that impacts how an individual thinks, feels, and interprets reality. I think the biggest thing to understand is that when someone's experiencing psychosis, they're going to have difficulty telling what's real from what's not real. And that can go across a lot of different domains, which we'll talk about. It's important to recognize that these experiences are involuntary and they're often very confusing or frightening to the individual experiencing them, as well as the family members and those around them. So what is first episode psychosis? You might have heard this term or FEP thrown around. It refers to the first time or period of time that someone starts to experience what we consider full psychotic symptoms. And so these symptoms might occur suddenly, but for most, there's a gradual buildup over months or even 1 to 3 years. At the STEP Learning Collaborative, we consider FEP or first episode psychosis to be within the first 3 years from when an individual has first experienced those symptoms, but people define it in different ways, sometimes up to 5 years, sometimes less, but really it's this early period. And it's important to note that an expected part of working with an individual with first episode psychosis is that diagnosis is not always clear. We expect that there'd be a lot of diagnostic ambiguity sometimes, and it tends to become clearer over time, right? Whether or not this would be a schizophrenia spectrum disorder or maybe more of a bipolar disorder with psychotic features. The exact nature and course sometimes needs to be followed over time to really delineate what exactly is going on for the person. But regardless of that ambiguity, treatment doesn't need to wait for a specific diagnosis, and treatment can start right away and focus on stabilizing symptoms and help support an individual's functioning. So what causes psychosis? Well, I'll get into a little bit. There's no one single cause. There's no blood test that we can take. It requires a careful medical and psychiatric evaluation. It can. So remember I said psychosis is an umbrella term. So psychosis can be triggered by various things, including medical conditions such as a seizure, epilepsy, Parkinson's, can also be triggered or worsened by substance use, especially cannabis, cocaine, or stimulants. However, once those things are ruled out, the most common explanation and cause for psychosis in a young adult or a adolescent is the emergence of a schizophrenia spectrum disorder or a mood disorder with psychotic features. And contrary to many myths, psychosis is treatable, and as we'll talk about, the earlier the better. So psychosis is more common than you might think. Maybe many of the folks in this audience today know that, but I think it's important to really normalize and try to help reduce stigma that psychosis impacts 3 out of every 100 people. And so that's saying that 3 out of every 100 people will experience some of those symptoms of psychosis, and 1 in 100 will go on to develop a schizophrenia spectrum disorder. So, and it cuts across all races, socioeconomic statuses, gender identities, etc. This is an illness that can impact anyone. And in Connecticut, we expect that there are approximately 500 new incidences of schizophrenia spectrum disorders each year. And 3 times that many folks will experience some type of psychosis or psychotic symptoms. So, what does psychosis actually look like? Um, well, first, we want to talk about when it typically begins. So, most commonly, it's going to begin between the ages of 16 and 35. So, this late adolescence, early adulthood. Um, Early changes in thinking, emotions, or functioning, what we consider a prodromal period or a clinical high risk period, often appear about 1 to 3 years before symptoms become more intense. And I'll talk about that differentiation in a little bit. Most individuals who go on to develop schizophrenia have actually had, an unremarkable childhood. And by that, I mean they were functioning typically, throughout elementary school, middle school, then maybe, around that adolescence time frame is where some of those subtle changes, like we talked about right here, maybe started to happen. And then typically, the peak age of incidence is actually 21 years of age. Sometimes a little bit later for females, a little bit younger for males. So right in that time where we're maybe going off to college, getting our first job, that's the time when we typically see um, the emergence of a full primary psychotic disorder for individuals. I will talk about a lot of different symptoms and experiences, and it is important to note that symptoms can look different for everyone, and also not every individual is going to experience every domain or type of symptoms. All right, so before I get into specifics of naming different types of symptom domains, I want to give you a sense of what psychosis can feel like. And these are some, quotes from young people experiencing psychosis, kind of describing their symptoms. So someone might start to pay attention to their environment and see signs. I keep seeing blue cars. I wonder if that's a sign I should pay attention to. Every time I hear my classmates laughing, I'm certain it's about me, right? So maybe some burgeoning paranoia there. Sometimes I feel like my thoughts are being broadcast out loud for everyone to hear. Everything sounds too loud or too close. It's like I can hear everything all at once. And what we know about psychosis is that there's often difficulty in the brain with what we call kind of sensory gating. And so the brain isn't filtering out um, non-salient information the way it should. So sometimes everything kind of comes flooding in, things that wouldn't have previously been salient or important start to become, the brain is telling them, hey, look here, this is important, pay attention to this blue car. And so it can be really overwhelming and confusing for individuals. And it's important to note, and I'll talk about this a bit more later as well, that of course folks can have sensory sensitivities for a variety of reasons, right? Various, you know, neurodivergence and things that have been long-standing for individuals. Someone might respond this way, but when we're looking for a burgeoning or new emerging psychotic disorder, we're really looking for a change from the individual's baseline. So this, if someone was saying this and this hadn't been the case for them before, I would look at it a little differently than someone who had a long-standing history of sensory processing difficulties or autism spectrum disorder. Another experience might be the voices, tell me that I'm no good and that I should hurt myself, right? That's an example of a command auditory hallucination, which sometimes folks experience when they're experiencing psychosis. Um, as mentioned, these experiences are involuntary, they're confusing, and they're often frightening for the person going through them. That is the modal experience. Sometimes folks, have experiences that they do find positive related to psychosis. It's not necessarily going to be the focus of today, but I do want to acknowledge that that absolutely can be true. So that gives you a kind of a sense of what things could look like or sound like. But now I want to talk a bit more about how these symptoms show up. What are the symptom domains? So we've got various domains of symptoms. The first and most recognizable would what we call positive symptoms. And when I say positive symptoms, I don't mean good. I mean extra or in addition to, or a distortion from an individual's typical functioning. So this is where you have things like hallucinatory or perceptual experiences. So hearing, seeing, even smelling, tasting, feeling things that aren't really there or that others aren't experiencing. This is also the domain where we have strongly held unusual beliefs or delusions. This might look like those kind of persecutory beliefs like paranoia, feeling like someone is plotting against us or there's this entire scheme going on. Positive symptoms might also include disorganized speech or communication or behavior. And all of these experiences are on a spectrum, right? They can all vary between people and even within the same person. So folks might, in that positive symptom domain, they might feel like they're being watched. They might believe that ordinary events like that blue car or that billboard or that commercial have a special meaning just for them. They might be responding to voices or other types of perceptual abnormalities. So that's the most kind of recognizable set of symptoms. But there's various other domains that are implicated. So there's also what we call negative symptoms of schizophrenia. And again, negative, I don't mean bad, but I mean a reduction from or a loss from someone's typical functioning. These can look a lot like depression, and it can be difficult to differentiate for families and sometimes even for providers. But so this is going to look like a person experiencing low or reduced motivation, less emotional expression or affect. They might even speak less than they used to. You might see a social withdrawal. And it might manifest as someone doesn't leave their room. They stop hanging out with their friends. They stop engaging in the hobbies that they used to. You see a drop in grades from a typically solid student. Again, all of these, you got to compare the individual to themselves, kind of how they're functioning before. So those are your most kind of common symptoms. Two other domains I'll quickly touch on. We can also see cognitive symptoms in schizophrenia. And so this might look like trouble focusing, trouble with abstract reasoning, difficulty with processing speed. You can imagine how this could make conversations difficult or school or work functioning challenging. And even if there's not a clear mood disorder like depression or anxiety or bipolar disorder, it's actually pretty typical to see some mood fluctuations in schizophrenia, anxiety, irritability, and increased thoughts of self-harm. And not everyone's going to experience all of these, but I wanted to make sure to kind of cover the full gamut. So I wanted to talk a bit about how these symptoms can occur on a continuum or on a spectrum. This here is actually an example from the SIPS, the Structured Interview for Psychosis Risk Syndromes. This is kind of the gold standard assessments to assess that prodromal period of psychosis. So I certainly don't expect family members to be familiar with this or to be asking these type of questions, but I want to utilize it to kind of show you the range of symptoms that folks can experience. So here's an example question in the kind of paranoia domain. Would be, have you ever found yourself feeling suspicious or mistrustful of other people? And so a response in the normal or typical range might be, Dr. Sykes, I don't completely trust my new roommate. My mom told me not to trust people right away anyway, right? So, okay, like nothing too concerning there. It's maybe the family is always a little weary of people anyways. It's not really interfering with anything. A response in the kind of moderate clinical high risk range would be, I think my roommate might be poisoning my food in the fridge. Sometimes I throw it out just in case, but I'm probably just being paranoid. So in this response, you've got someone who's, and we'll say for the sake of this, that we know that they're not being poisoned and the roommate's not out to get them. They're, pretty concerned, pretty distressed, and pretty convinced about this idea that their roommate is poisoning them, so much so that it's impacting their behavior. They're throwing out their food, but they're spontaneously able to question that at times and generate insight. And they say, oh, you know what? I'm probably just being paranoid. So if we were to ask a couple more questions, maybe we find out that this is only happening sometimes and they're never 100% convinced that it's happening and they have some doubt. So we'd still consider this the prodromal or clinical high risk range. A response that would indicate kind of full or frank psychosis would be someone responding with, I am certain that my roommate is out to get me and is poisoning my food. Sometimes I don't eat for days. So as a clinician, I would look at that and I would see, okay, this person is fully convinced of this belief that their roommate is poisoning them. It's impacting their behavior so much that they are neglecting their medical well-being. I might even consider them what we'd call gravely disabled, and even consider that they might need to go to the hospital for support, depending on how potentially malnourished they might be or how much this is impacting them. So at this point, we would consider this kind of a full psychotic symptom. It's significantly impacting them. They're fully convinced, so there's no insight into this. And at this point, that this person would consider them having an episode of psychosis. I won't get into necessarily all the details, but once someone reaches this range, they don't necessarily go back into the clinical high risk range, although we would call it residual symptoms. So then, certainly after someone has experienced a full psychotic episode or symptoms where they've lost the ability to doubt, or it's interfering with their functioning, they might experience kind of lower level symptoms over time. And we just would consider it kind of residual or low level or breakthrough symptoms. So again, you don't need to know how to do this assessment, but wanted to give you a sense of the continuum. All right, so I did want to share with you a 3-minute video. Hopefully the audio works. So maybe Aisha, you can give me a thumbs up if it is working. The STEP LC had a chance to interview a bunch of students from the organization, Students with Psychosis, and I wanted to just let individuals with actual experience kind of share what it's like for them.
For 6 months straight, I would get on that bus, 5.5 hour bus ride there, 5.5 hour bus ride back to get the nonprofit off the ground. I would talk to my psychiatrist during that time, and he was asking very, very personal questions, very much treating like this whole going to New York, founding Students with Psychosis was some delusion or a grandeur. And let me just say, it wasn't. I can't even express how proud I am.
It's like you see a hallucination and you're like, is that real? It's that confusion. And it feels so real.
I thought the other soldiers could see my thoughts, so I would say random things, and that would they didn't know how to handle it.
I started to go to a psychiatrist after my parents saw my behavior change. That was like when I was 12, 13. At first, I felt overwhelmed. I thought anyone could do to help me. I didn't think I was capable enough to hold a job, capable enough to go to school.
I hallucinate all day, every day. And a lot of people think that you can't function if you're having visual or audio hallucinations.
People tend to think people with mental health disabilities, for some reason, do not have the ability to intellectually take care of themselves, to learn, to prosper, to do well in life, and we are perfectly capable of that.
I think I've met, a range of people with schizophrenia and psychosis, and we look like anyone and everything, and we have a range of interests and things that we all care about, and we're just people like everyone else.
When I was told that diagnosis, I felt like, how could I have something like this? And I was also scared. I knew something was dreadfully wrong with my mind, and I wanted to do something to improve it.
It was, I suppose, a relief to understand that what was wrong with me and be able to get treatment, as it was very hectic, having continuous psychotic breaks and being in and out of the hospital.
She shares with me that it was her magic medication that did the trick, and what I saw was she was really given specialized care and the support she needed to start to rebuild her life.
It was a realization of, what do I need for myself in terms of accessibility in education spaces, behavioral health spaces, community spaces? What do I need at home?
Seeking treatment is aligned with your own self-agency. It's still your life, your body, your mind. Doctors and treatment is a tool to help you live the best version of yourself.
this concept of lack of insight or ansoagnosia. You don't have to know how to pronounce that. It's taken me a while. But I think this is a really important topic, and sometimes it's not mentioned early on, and kind of families and caregivers feel alone or confused at this part of the illness. And so what is this idea of lack of insight? So as I mentioned, it's also called ansoagnosia, and it means difficulty recognizing that symptoms are a part of an illness. So this commonly occurs in early psychosis. Anywhere from like 50 to 80% of individuals experience some type of lack of insight, either full or partial. This also occurs in other kind of like neurological disorders and things, but we're talking about it in relation to psychosis here. It's important to recognize that this is common. This is part of the illness. It's expected. It's not your loved one being in denial or being stubborn. It's actually a brain-based change in self-awareness. And so for individuals experiencing this, because the illness doesn't feel real to the person, they may genuinely believe that nothing is wrong, right? So you might hear things like, nothing is wrong, I'm not sick, I don't need help. It's not me, it's others that are misinterpreting what's happening. And so maybe, clinicians or family members in this room, or even if we have any young people themselves, they might resonate with having experienced this at one time or another. So does insight improve? What helps? Insight can actually vary, day to day, and it often improves as symptoms stabilize. Improvement's particularly common in the first year after treatment begins. And not necessarily because the medication or therapy targets the insight, but as symptoms stabilize and those treatments can reduce positive symptoms and things like that, and individuals able to become more reflective and able to reevaluate their experiences. And they're also, with treatment, experiencing less of that input, less of their brain kind of saying, hey, pay attention over here, this is salient, be paranoid, be suspicious. When there's less of that happening, it's easier to kind of recognize that what's real and what's not real. As mentioned, treatments can help with insight. Medications like antipsychotics can help reduce the symptoms that can make insight difficult. And therapies, even supportive or cognitive behavioral therapy for psychosis can help folks learn to reflect on their experiences and consider alternative explanations. So why does this matter for families? I think it's pretty obvious. Probably many folks in this room have experienced this or are currently experiencing it with their loved one. Lack of insight can make it harder to seek and stay in care, right? If there's not that awareness that something is wrong, something's interfering with their life, why would someone want to seek help? Certainly, it can increase distress, conflict, and frustration for all involved. But just understanding this concept of insight and ansoagnosia can help promote compassion and also reduce blame. We're not going to talk about it today, but we've got 2 sessions dedicated on strategies and communication skills coming up, and we'll talk about some ways that supportive communication, even with an individual experiencing minimal insight, can really help. So why does early treatment matter? Because without it, there are serious impacts, right? So not everyone, but most folks, as I mentioned, right, if we're thinking about early childhood, we've got some kind of like typical functioning. Maybe there starts to be that prodrome in adolescence, so functioning dips down a little bit. And then all of a sudden we have that first episode of psychosis where all of a sudden things become more intense, we lose insight, and then typically we see a sharp increase in symptoms and a decline in functioning. So as I mentioned, this is typically occurring between 16 and 35, with that peak incidence at 21, right at the time when a young adult is launching into important things in their life, this transitional age, right? So when this happens, we see disruptions in school. Maybe if individual will have to take a medical leave or drop out of school, maybe they lose that first job. Those early relationships, either with family or significant others, start to suffer. It's really a critical age, and without treatment, loss of functioning can be pretty dramatic. And again, without treatment, many folks will have kind of recurrent episodes, and that might mean sometimes recurrent hospitalizations. Also during this time, particularly during the first 5 years, kind of this early first episode psychosis time, there are increased safety concerns, specifically related to suicide risk. It's highest for folks within the first 5 years after onset of psychosis. As many as 10, sometimes upwards to 20% of individuals experiencing first episode psychosis will attempt suicide. And so it's incredibly important to help folks get into treatment, as we'll talk about, and just simply being into treatment, not even necessarily specialized treatment, can really help reduce risk of suicide. Also, I want to acknowledge, right, there's often the sensationalist idea that's portrayed in the media that individuals with schizophrenia are violent. And those links are incredibly exaggerated. And so although there is an increased risk of aggression or violence in individuals with schizophrenia compared to the typical population, and it's modest, what we know about that risk is that it's highest for folks who are not in treatment, and who have comorbid substance use disorders. And so once we kind of get folks into treatment, as I mentioned, that's one of the best things that we can do to really mitigate that risk, both towards oneself and as well as aggression towards others. And so I did want to mention that, but really the bottom line with this is that the majority of people experiencing schizophrenia are not violent, and it's vastly exaggerated in kind of what we see in the media. So that was a lot of kind of doom and gloom and talking about the negative potential impacts. But that was without treatment, right? So I do want to emphasize that psychosis is absolutely treatable, and the earlier the better, but it's never too late for someone to improve in their recovery. We like to say that recovery is the expectation, not the exception. So we expect that folks that get into care for early psychosis will improve, that they will respond to medications. We know that early treatment matters, and it's associated with greater symptom reduction, better school and work outcomes, right? Folks either improving or getting back to school, getting back to work, having important relationships, getting married, whatever it might be to them. With treatment, there's lower relapse of symptoms and lower hospitalization rates, certainly reduced risk of self-harm and harm to others. When folks are in treatment, there's much better long-term outcomes, reduced chance of kind of long-term disability. So we know that most people improve significantly with early and consistent treatment. And I've myself have worked with various people of all sorts of professions who've experienced schizophrenia and who stayed on track or gotten back on track with their life and their goals, including doctors, pediatricians, lawyers, accountants, mothers, all sorts of people. So there are a lot of examples out there in the world of folks living successful, meaningful, rich, and fulfilling lives with schizophrenia. So what are some warning signs and risk factors? What should I look for? So perhaps the folks in this room don't need this piece because you maybe already, as we saw from our poll, supporting young people with early psychosis. But it's important to know maybe you're going to inform loved ones or other people. We know that family and friends are often the first to notice when something's off with a young person. Early warning signs might include withdrawing from friends, family, usual activities. So kind of those negative symptoms that I was talking about. You might not know what's going on inside someone's brain or in their head, but what you'll see is maybe, right, reduced motivation, that drop in grades. Maybe they start to act suspicious, changes in behavior. Maybe they say that they're hearing or seeing things that others aren't, or you might see them talking to themselves, which maybe wasn't typical for them before. A lot of times people might, have some of those early cognitive symptoms in adolescence, trouble concentrating or organizing. And maybe folks are presenting to the doctor or saying, I think I've got some late onset ADHD. And of course, as we know now that there certainly can be diagnosed ADHD later on, but typically, right, you're going to want to see evidence of attentional or ADHD related difficulties in early childhood and early schooling. So what I do when I'm talking to pediatricians or primary care or families, I just want people to know that that should be at least a red flag in your mind. It doesn't mean that just because someone's having attentional issues that they automatically have schizophrenia, but it should be a question in our minds, a differential. Okay, is this attentional difficulty happening because there's actually an emerging psychotic disorder going on, or is it anxiety or a true ADHD problem? So especially because the introduction of stimulant medications for individuals experiencing early psychosis could actually exacerbate their presentation. So we just really want to be mindful of that and kind of have that in our brain if that's kind of what we're seeing and what folks are presenting with. Again, to hammer home, it's hard to say exactly what to look for, but you know your young person. So if these are changes from how they used to be, from their baseline, that's the most important kind of sign that you can really look for to know if something is progressing. So as I mentioned when I was talking about what causes schizophrenia, there's no single cause. We like to think of it that it's a stress vulnerability model, that there's some type of genetic or early vulnerability that interacts with some type of environmental or life stressor that might result in the development of a psychotic illness or exacerbation of symptoms. So it's no one thing. I'm not going to spend too long on this, but it'll be available for your reference. This is a list of various risk factors for psychosis onset. I want to highlight a couple. Oops, going in a different order. Certainly a family history of psychotic disorder is relevant. This is a heritable vulnerability and condition. So if you have a first-degree relative, parent, sibling, an individual 6 to 13 times more likely to develop a psychotic disorder themselves. Early experiences of trauma can increase risk. It's thought that about 34% of individuals with first episode psychosis had experienced some type of childhood sexual or physical abuse. However, it's important to mention, so even though trauma can increase one's risk, not everyone who develops schizophrenia has experienced trauma, and not everyone who experiences trauma will go on to develop schizophrenia or a psychotic disorder. And also, I'll spend a whole slide on this, but once we're kind of into that late childhood, adolescence, young adulthood, certainly substance use can really be a risk factor that perpetuates the onset of an illness. So I did want to focus on that because that's often what families and providers have the most questions about. They're like, talk to me about cannabis. So cannabis or marijuana and psychosis, there's absolutely a connection. Adolescent cannabis use increases one's risk fourfold of developing schizophrenia spectrum disorders. Okay, so let's sit with that for a second. Use of cannabis products and exposure to it, the earlier the use, the more frequent, the higher potency use, all raises risk of developing a schizophrenia spectrum disorder. So it's thought the various things that perhaps cannabis use, especially in someone who's already vulnerable, like someone with a family history of schizophrenia, that could be the thing that kind of brings about that vulnerability and perpetuates the onset of the illness. But it's also believed that about 15% of new psychosis cases are attributable to cannabis use. So meaning that if the cannabis use wasn't there, the schizophrenia wouldn't have developed. A lot of times people are asking me and wondering about substance-induced or cannabis-induced schizophrenia or psychosis, which absolutely is a real thing. But it is important to note that when that happens for someone, 50 to 75% of those individuals later go on to develop a schizophrenia spectrum disorder. When I'm talking with young people or clients and they have siblings and things like that, I try to, if we're not abstaining from cannabis, try to at least delay our use until we're 25 after the brain has had some more time to develop. Just referencing a couple resources here that will be available to you. We have a really kind of layperson friendly blog talking about the link between cannabis and schizophrenia. We also have these cards that we hand out at events or have in waiting rooms of college counseling centers to try to educate young people about the risks of psychosis or cannabis use and psychosis. So we've talked a lot about risk factors, early warning signs, but right, we're here as family members or even clinicians, and it's hard. It's hard to recognize psychosis early. And a lot of times there's, enough blame and shame being thrown around. And I want to take a minute to try to dispel that a bit, that it can be hard to recognize early symptoms. A lot of times they might be mistaken or can look a lot like normal teenage behavior. Okay, yeah, my kid's spending more time in their room and on screens. I didn't think anything of it. What teenager isn't, right? Sometimes we might attribute changes in a young person to stress, school, life transitions. It can be hard because changes might happen gradually. And also there's a lot of stigma that still exists, both to the individual experiencing the symptom. They might be afraid of what their experiences mean, so they hide it or minimize it. Or family members might also be fearful of it and want to, understandably dismiss it again as a normal change going on. Of course, lack of insight can make it hard for young folks to come forward or have awareness of their experiences. And then once, even though we recognize what's going on, it can be really challenging to find care and navigate the mental health system. So there's a lot of things that can make it hard. But what's important is that, when you do start to see symptoms or recognize something's wrong, you don't need to be the one to know exactly what the diagnosis is, but seeking help. And I'll talk about how the Step Learning Collaborative can provide that as one resource. So we've provided a foundation, and now I just want to talk a bit about pathways to care in Connecticut, what we're doing here. And so that's where the Step Learning Collaborative comes in. The Step Clinic is a physical place in New Haven, but the Step Learning Collaborative is our statewide initiative, and we consider it our Connecticut's learning healthcare system for recent onset psychosis or schizophrenia spectrum disorders. And you can watch a whole video on that to explain it better. I'll really just let you know the main things that you need to know. So the goal of the Step Learning Collaborative is to deliver safe, timely, and effective pathways to and through care for every young person in Connecticut experiencing a first episode psychosis. So we have launched, as of February 2024, a centralized referral number that anyone in the state can call. Young person, parent, clinician, hospital, teacher, whoever it is that might be concerned about a young person experiencing psychosis, they can call and speak with a member of our team to try to sort out what's going on. And if the young person's ultimately agreeable, we can help direct them to care. And this represents the network of all the clinics that we're connected to where care will be provided, including the STEP clinic in New Haven at Connecticut Mental Health Center. So how is the STEP Learning Collaborative supporting families? As I mentioned, there is now one centralized referral system for the state. You can call our centralized number, and we have the people answering the phone are what are called EDACs, Early Detection and Assessment Coordinators, and they're pictured here. They're wonderful, highly trained and experienced individuals who will hear the concerns. Most times it's family members or clinicians calling us. Rarely it's the young person themselves, although we do receive self-referrals. We'll talk to you about what's going on. We'll try to make a rapid assessment of whether or not we think this is psychosis and if the individual meets our eligibility criteria, which you can see right here. So individuals 16 to 35, having recent, so approximately 3 years of onset of psychosis, must live in Connecticut. And what's really great about this initiative is it doesn't matter your insurance status. You can be commercially insured, be on Medicaid, Husky, or have no insurance, be undocumented, whatever it is. If the individual is eligible, we can help direct them to care, and that will not be a barrier. Our goal is to have rapid access because we know that getting folks to care quickly is important. Reducing that duration of untreated psychosis is critical. Our goal is to get folks into care within 7 days from when they're determined eligible. We're still working on that, but I think on average across the state, we're getting most people in within 14 days, and at STEP, our wait time's pretty much 0 days. The EDACs are also offering evaluation and ongoing assessment every 3 months. We're supporting the agencies that are accepting these individuals into care. We're also supporting the family members with education. So at the 3-month mark, 90% of folks that have engaged in the STEP Learning Collaborative are still in care. And as I mentioned, we're doing a lot to support the workforce. So we have regular meetings with all of the agencies that accept these referrals. We provide them various trainings. We provide them provider-to-provider consultation, free continuing education credits, training, various things to really help support care quality and ultimately the care and outcomes of individuals experiencing psychosis in our state. So how to refer? Centralized referral line. We have an online referral form. This will all be available to you. And now I will hand it over to Aisha to review some myths versus facts.
Yes, so we're gonna go through 6 common myths, and I'm mindful of the time, so I'll try to go a little bit quickly, but not too quickly. So the first one that we have is that psychosis is really rare and that no one in my life will be impacted by psychosis. Well, in actuality, we know that, and how Dr. Sykes talked about it earlier, it's more common than we think. So 3 in 100 people will experience psychosis, and so it is a condition that can impact anyone, and it looks different in everyone. We have our next myth, which is treatment doesn't work. And so a lot of people think that people with schizophrenia is a death sentence and that there is no hope for them or how their life may be. And so there's kind of no hope of what their life will look like after, which we know is absolutely false. And so we do know that treatment is effective. And of course, the sooner someone gets into treatment, the better. And so people living with schizophrenia can live happy, healthy lives and be very successful and have a meaningful life. And so, whatever this may be to them. So, this could be having hobbies, going Black Friday shopping, having children, playing sports, getting married, having a job, living independently, having a pet. So, all those different things that may feel meaningful to them. Our next one is that treatment is scary and painful. And so, we do know that treatment is safe and it typically involves often going to an outpatient appointment once a week. And, this could also be going home and having telehealth appointments as well. But sometimes treatment can involve psychiatric hospitalization, but it doesn't have to be scary. We also, or people kind of speak about that treatment means being in a hospital or psych ward. And so our goal is to get every individual experiencing psychosis into care on an outpatient basis before they end up in a crisis situation where they end up in a hospital. However, I do want to be mindful that hospitalizations can happen for many individuals and where they may need more immediate stabilization or evaluations. But we do know that ongoing treatment in the community is typically in outpatient offices, and outpatient care does work in ways to prevent folks from being rehospitalized. We also have that using cannabis and safe. And so as Dr. Sykes just talked about is that cannabis use is a big risk factor for psychosis. So of course, adolescents' cannabis use leads to a 4-fold increase in developing psychosis or schizophrenia generally compared to those who do not use. And so earlier or more frequent or high potency use raises risk even more. And the last one that feels pretty important to talk about is that a lot of people think that what people are experiencing when they're living with psychosis is not psychosis, that it's their personality or it's a curse or it's laziness. But what we know is that psychosis is real. It's a medical condition. It's not a personality problem, weakness, or even lack of willpower. What we do know is that when symptoms become confusing or distressing or they begin interfering with a daily life, that's when treatment is needed. And so with early support, most people can improve significantly.
Great. Thank you so much for going through those. I think that's a nice summary and reminder of some of the takeaways from today. Before we touch on the Q&A, I just wanted to remind folks of resources that are available to you. And so this will be a helpful slide. Again, it'll be available and we can also put some links in the chat at the end. The best thing you can do if you want to stay up to date on trainings, resources, blogs is sign up for our email list. We send an email about once a month, sometimes less because I don't always get around to it. So we won't be blowing up your inbox, but I think it's a great way to stay connected. Our STEP website is the kind of portal for everything. Our YouTube channel has all of our previous trainings. This will also be made available on there. And it has a lot more of those videos and voices of lived experience that we showed. Here's just a look at some of the educational blogs that are available on our website. So how to effective communication strategies for parents and clinicians. That cannabis blog I was talking about, it's actually the most trafficked website on the Department of Psychiatry's website for Yale. Lots of people are going to find that information. We also have tips for supporting young people in schools and analyses of kind of the latest literature in layperson terms.